Colleagues, I believe if it's all right, I'm going to start now. My name's Jasmine and I'm from Patient's Opinion and Care Opinion. Has anyone heard of Patient's Opinion?
Don't put your hand up, Jane.
All right, well, it's nice to see a few friendly faces. Before I start, obviously this is the online feedback for health and social care. This is about patient engagement. And I was asked to do this session, so this isn't an apology, but I'm more or less saying how I'm going to open the session, because I'm as interested, and because we're being filmed, I think the people out there on the World Wide Web, or wherever this is going to end up, are probably more interested in hearing what you've got to say and your experiences than me. So I just thought I'd kick-start the discussion with a little bit about my organisation, if that's all right with everyone, because we've been, knee-deep in patient engagement. And well, I'll explain that in a minute. Now, before we start, it would be great to get an idea, for who's here. So I'm Jasmine Ali, I'm from Care Opinion and Patient Opinion, and I'm delighted to be here. I'll start with this side, if I may.
Okay, I'm Jeremy Labrum. I'm working for a consultancy working with Kent County Council on transforming adult social care. My particular interest is in a project called Promoting Independence Reviews, so looking at existing social care cases and seeing where we can discover opportunities for increasing social care customers' independence. And if that saves resources, that's great, yeah? So I'm really interested, sorry, this is a very long introduction, but what I'm very interested in is if we have the means by which we can measure people's opinion of their level of independence before and afterwards, that would be great. Because otherwise we're just going to measure the amount of money we spend before or after, which is maybe a good proxy for increased independence, but it may well not be. So am I going to be really pleased about what I hear?
Well, I hope so, because we're going to have a general discussion, really. Okay.
I'm Jo Beryl, I'm from NHS, I've done at CCG.
Okay.
I'm Laura Embry, I work for Kent County Council in the Family and Social Care Directorate, and I'm a project officer for Dementia Friendly Communities.
Okay, nice to meet you.
And I'm Peter Marsh, and I'm also a project officer for Dementia Friendly Communities.
Okay, excellent.
I'm Paul Williams, I'm a locality support manager for Kent Adult Social Care covering the Dartford Greater Swansea locality.
I'm David Hostock, locality organiser for Kent Enablement Home, which is the KCC enablement service.
I'm John Biggs, a practice liaison manager for Canterbury Coastal CCG.
I'm Nick Saunders, I'm a director for a domiciliary care provider in Kent.
I'm Sophie Turley from Centre for Independent Living Kent.
I'm Jo Empson, I'm a commissioner for Kent County Council leading on home care and reablement.
My name is Emma Hanson, I'm the Head of Strategic Commissioning for Kent County Council for all community-based services, adults.
Okay.
I'm John Perry from Care Marketing Settlements. We're a fairly recently opened domiciliary care business.
Okay. Yes, please.
Hi, I'm Sandra Springer, I'm from AGK in Tunbridge Wells. Particularly interested in this because we've just started a new dementia service, and we're interested in doing support for the families, but also we want our service to be very much led by what they want as opposed to, and also for demonstrating how good we are and how valuable that is to the commissioners.
Yeah.
What's your social return on investment, Sandra?
And the backbenchers, we can't leave these out, seeing as we are being filmed.
Hi, I'm Chris Bolton, I'm from Wales Audit Office.
Okay.
And I'm James Seaton, you already know me.
Okay. We all go.
I'm Paula Wilkins, I'm the nursing director from Hospice in the Weald in Tunbridge Wells, and really involving patients and getting patient care or feedback is quite difficult in end of life, and I'd like to, it looks like a really good way of enhancing that.
Thank you.
I'm Catherine Benner, I'm an occupational therapist with the assessment
I'm James Lamper. I'm a commissioning manager at Kent County Council, and I'm really pleased that you're here today because there's quite some interest, certainly from the chair of our Kent Health and Wellbeing Board, in relation to how we listen and read to what people are saying about health and social care services.
Fantastic, thank you. Well, we've got a good start. We've got a good mix of people here, so we should have an excellent discussion. Okay then, to kick it off, I'll tell you a little bit about our online tools, but I thought in order to get us there, I wanted to talk a little bit about social media. Are you all on social media? Are you all on Twitter? Hands up? Yeah. You all on LinkedIn? Yeah. Facebook? Oh look, I'm speaking to the converted, but you know, I'll show you what I've got. And then I've got an introduction to care opinion, which is my reason for living at the moment, and hopefully when you leave here, your reason for living. And we'll preview some of the key issues, because I can see that we've got quite a cerebral bunch of people here. So, you know, we'll have a little bit of time on some of the key issues around patient engagement. Okay then, the power of the internet then, impact of Web 2.0 technologies, we already know that. They create and share content, communicate in real time across boundaries and hierarchies, change the way that people relate to services. It's interesting, but it's that top-down thing that really makes me smile. I had these graphs, and now I realise the cultured audience that I've got, I wish I'd brought them now, but they were graphs which were done by this doctor or a physicist in the 1970s, and he was sucking his pencil thinking, how would people relate in the event of a nuclear meltdown? And so he had these like DNA models, you know, you can imagine, and they had like the top-down model. And it was like, well, that's never going to work if there was a nuclear meltdown. And then there was more of you know, where they worked across, or as we call in the professions, you know, flat lines of hierarchy. That's not going to work. And then he made this other graph, which was exactly like the kind of graph that you see, like a DNA map for Facebook, you know, an integrated way of working. So, in the event of a nuclear meltdown in the 70s, this, you know, they were proposing this way of working, and it's quite interesting that those maps are being used today to show how we work in social networking. And what's more interesting for a subversive like myself, we'll edit that out. Filming. But what's more interesting is this idea. Oh, okay. This idea of top-down doesn't really work, does it? I mean, top-down, if you've worked in government, you know, that's a way of relating. You know, you have an idea, you send a memo, and someone changes the way they work on the front line. And also, you know, this idea of flat lines of hierarchy, which, you know, the private sector really like. That's not really good at, you know, at working anymore. But actually, thanks to good old social media, this idea of knowledge is power, you know, that's no good anymore, because actually, if you are, you know, quite keen, you might be more up to date on the news and what's happening in your organisation or your local council than the leader or the chief executive. So, you know, I think it does show that this top-down way of operating is kind of redundant, really. As I will be when I finish this live streaming, no doubt. Okay, patient opinion then. We have been at the forefront of these new technologies for over the last 7 years, and it was put together by 2 GPs. They haven't been struck off or anything, but they wanted to change the world in a different way other than saving lives. And they put together, you know, they saw social media and they thought it could really change the way that we relate to patients. And so they came up with, well, patient's opinion, using the transparency agenda to drive change on patient's opinion. And so people being on patient's opinion. So you've seen it. Okay, patient's opinion is where you can actually say what you think, and you can tell your story about your experience of the health system, the NHS. And actually, contrary to popular belief, because we know it's the NHS birthday, you know, and we can see that actually a lot of people are very critical of the NHS, you know, and I'll leave that there. But actually, a lot of the comments that we get, the majority of the comments we've got are in praise, you know, of what people think about their care in the NHS. And the critical ones, which is really what we're interested in, because actually we want to do this for a purpose, and that is to change. and improve the way we run our services. So the ones which are critical, they get faster response than if they went through the complaints department. Much less bureaucratic, more real time, and people change the things that really irritate people very quickly. So that's in a nutshell. And it's interesting, I use this slide because it's very current, isn't it? The Mid Staffordshire NHS Foundation Trust. And you can see there that stories have been loaded on there. And we'll come on to Francis in a minute. And then you can see, it's so intuitive, this system, because you can see the activity, staff members have read this story, and you can actually see who's reading it. So someone will publish their story, and then someone can come back, the hospital can come back and respond, and then the world can read that story, MPs can read it, frontline officers can read it, there you have it, it's transparent. Obviously, the thing about good old social media is that everyone can comment. You can read this, I'm sure you can pick it up on the phone. Dear Doctor, on the wrong side of 35, please don't say good girl to me whilst fitting in IUS. However well then, you're a woman and I'm a woman. So, the thing is, thanks to social media, it's out there anyway. Now then, are we talking about a revolution? And I would say we are, because I've been doing some work with early adopter authorities, and we'll come on to that in a minute. But one of the things that people say, because I'm, a bit ahead of myself, and sometimes I'll write their communications plan for people that I'm working with to help them. And then, obviously, you get the process of edit, and then someone might say, oh, revolutionise social care, that's a bit strong. And they cross out the word revolutionise and they put in the word improve. And I just think, I'm sorry, but I'll take any amendment. I'm not precious about my work, but I'm not taking that one, because actually, everybody lives their life in a much better way thanks to technology. People don't queue up to pay council tax, do you? If you want your rubbish removed, you go online. You don't wait in like the bad old days, or just get fed up and then pay someone 100 quid to take it because you're fed up with waiting for services. People are improving their lives all the time with social media. So why not, the most disenfranchised people, that we know, of course, people who use social care, the most vulnerable people in society, patients, need to use social media. Okay, one of the things that I'm very excited about is patient opinion. I mean, many of you have heard about this and many of you have used it. It's been running for 7 years. It has a lot of stories published. It's improving services as we speak. Now, the good old DH gave us some start-up funding about a year ago, which is where I came in because my expertise is very much local government and social care. So they said, we'll give you some start-up funding and we'd like you to, roll out patient opinion to a social care audience. And I can see the eyebrows touching hairlines, because if it only was that easy. So while we were putting it together, I did the right thing. I actually spoke to people about what they would think this service would be. And of course, you could tell me now, I mean, the things that came back is, if the social care audience get wind that you've taken something that worked really well in health, and you're just tagging social care on the bottom, then, it's never going to work. So, we thought about it. We didn't call it patient opinion, we called it care opinion to signify that it was looking at a different audience. And, we really thought about what the differences were. I've been working with early adopter authorities. I'm working with Sheffield and I'm working with Southwark. And anyone else who's interested we'll work with. But what we're doing is we're testing the system because we put it together rather quickly. I mean, it's interesting because in my old day job and in your day jobs, if you have a good idea, depending on how good it is, it can take weeks, years, well, usually years to see the light of day. But the good thing about technology is if you have an idea, there's no boundaries really. I mean, whoosh, it was knitted together, although the developer would probably be grimacing at my description, but it was put together and developed carefully over 1 year. And we went live on time, April this year. So we're working with the early adopters just to test some of these. But what we've got now is an online narrative feedback. So basically you can take in any feedback and relevant agencies are alerted straight away, the providers, the hospitals, because we're talking about linking health and social care. And this is just to show, you know, one of the things that we had to deal with, because in healthcare, it's very different. I mean, I know that, you know, it's the order of the day, isn't it, to integrate health and social care? Of course it is. But it also has been the order of the day for the last 40 years, really. So we must acknowledge the differences. You know, hundreds of big providers versus thousands of providers. So, you know, that's where we are. Now, I mean, one of the things that I wanted to cover before we open it into discussion is, if not now, never, I would say. Because obviously there's this powerful integration to integrate health and social care. But then, you know, underpinning this is this powerful, you know, powerful example that we have to actually listen to people in a way that we have never done before. And if you think about the Francis inquiry into mid-staffs and the NHS Foundation Trust, February this year, I mean, there was a lot about that, about listening to people. But we would argue, you know, or my colleagues at Patient Opinion would argue, that even then, you know, it looks a bit dicey, because Francis is very important, but then Francis talks about the importance, you know, of listening to patients, of listening to service users now, but actually they're talking about data. You know, and I think that kind of misses the point, and I'll explain what I mean. What we're trying to do is collect stories, not just data. I mean, we work with Sky, you know, who are really excellent, finding good care, but there are a lot of systems out there, and they are interested, you know, in actually comparing, comparisons, and so on. The thing about what we want to do about patient opinion, I mean, it's interesting, because Francis, doesn't he, talks about how you can get compassion. You know, all of these horrible things that have happened to people, how you get compassion. And then Alan Johnson, when he was the Health Secretary even, he said, actually, you know, you would how would you measure compassion in a hospital? You might measure the amount of times you see a nurse smile. You know, so you can see that people are getting really knotty issues about this. And one of the things that we want to do is to get the whole story. And that's what Care Opinion is doing. I mean, it's funny, but, you know, we met CQC, formerly of the DHM, is it David Behan? We met him, and we told him all excitedly about Care Opinion, and he knew about Patient Opinion, obviously. But we told him about this, and as we were leaving, he said, Jasmine, he said, you're ethnographers, aren't you? And I sort of said, oh, what do you mean? He said, oh, you know, you're interested in the full picture. Do you remember in the 1970s, people used to do those deep dive studies where they'd actually, you know, be really involved with the subject of research. So it wasn't just a, you know, number thing. It was actually quality. So that's quite a nice way of describing it. The other thing I wanted to say about how you link actually talking to people, talking to service users with this transformation agenda on personalisation. Because obviously this is, you know, technology, you know, Care Opinion, Patient Opinion, and then you've got, you know, the order of the day is how you can actually use technology to have you know, people are familiar with this idea of the e-marketplace, and where users, you might not need feedback, because actually users would be empowered to actually hire and fire their providers, you know, online and in real time. You know, there's that kind of aspiration. So when I talk to local authorities, they say, well, you know, we really want to work with you, but we want to make sure that you can work with personalisation, you know, and all of these other agendas. And that's one of the things that everyone has to do in this area, is to make sure you're future-proof and that you can talk to other initiatives. Safeguarding, that's a big issue, you know, which we can come on to in the discussion. And of course, I love this cartoon. It's got two, I'm an owner of 2 Jack Russells, and it's one dog saying to another, on the internet, nobody knows you're a dog. So obviously that's the issue of moderation. So, you know, how can you stop people using, you know, Care Opinion as, you know, as their hobby horse? Or, you know, you can actually tell by reading it that maybe it's some provider is saying that their services is, you know, the Beasleys and everything. Or, you know, if you're familiar with social care like I am, sometimes you can get stalkers, but I don't mean that in the way that, you know, I mean it that people will chase you for that kind of W2 postcode, or they want, you know, things, and they will constantly write letters. And now they've got this, what's to stop them constantly harassing frontline workers with technology? Well, I'll tell you what, you know, one of the things that we do is we moderate all the comments. We have a team of moderators. A modest team, there's about 15 of us, and when the postings come through, we helpfully tag. So there's a huge story now in front of you explaining about the patient's experience. And so what we'll do is we'll say, that's a council, that's healthcare. And so we tag it rather helpfully for busy people who could just say, right, is this affecting me? Do I need to be involved in it? So we tag it. But what we also do is take any invective out, or take any, you know, names out. It's all anonymous. So I wanted to talk to you about that. One of the things I wanted to say, the key factors. It's a key factor for us, but I would have said that it's a key factor with any kind of consultation or any feedback. And that is, you know, one of the things we do is establish the power to publish. We enable service users, relatives, carers to publish their stories online. We promote integration because we've got the patient opinion and we've also got care opinion. I mean, someone used this nice analogy. It was a developer that I work with, and he said, you know, when people ask questions on this, he said that he went to India once with his partner, and one of them wanted vegetarian and the other one wanted meat. They went into this restaurant. There were basically two restaurants, they thought. One was vegetarian, one was meat eating. And when they got in there, they were in the same restaurant. So, you know, one of the things that we want to do with our knowledge of health and social care is to, you know, really bring these services together and put them through tagging. Establish accountability. You know, it's very service user centred moderation, I have to say. And we can improve localism because we know the architecture, although it's changing even as we speak, but by connecting to Healthwatch, local health and wellbeing boards, safeguarding boards, housing and complaints, we can kind of improve localism. Okay, care opinion metrics. Then all I wanted to say is that the key metric is we're in this to improve services. We're listening to patients in order, and listening to service users now in order to change society and the world and their services. I've got these lovely graphs that I wanted to show you. They might not translate too much in the film, but these are all about integrating conversations on patient opinion and care opinion. You know, you've got the service user, the story, the care home, the responses. And we're not, one of the things, when you talk to civil servants, are there any civil servants in here? No, okay, oh great, I can say this, I'm sure there's a few out there. But whenever I talk to civil servants, they always say, it's about the volumes, you've got to get the volumes. And then you just think, well, obviously that's true to say about anything, but actually, one of the beauties of this, you know, people telling their stories, is that it doesn't have to be about the volumes, it's about quality. And I've got this lovely slide here. Oh, there it is. It's about the role of the thoughtfully passionate, and they are key to improving services, because you've got people who are indifferent, people who are concerned, but people who actually have something to say about their service, or about the service that their mum, their dad, their friends have had. You know, they put their stories online, and so, you know, there's a space, you know, thanks to social media, for people to change services by doing that. It's around, you know, people with learning disabilities, older people services, so anyone using social care. And obviously, whereby we think, you know, people always say to me, you've got to be accessible, what about the digital divide? And we've got, you know, people aren't online. We've got leaflets so people can actually write their stories, or have someone write them for them. And then I'll type them out and put them onto the web, and people can get responses. So really, we're hoping it will be, you know, as inclusive as possible, really.
So you see in a real age,
yeah,
span of age on patient opinion?
Yeah, definitely. Yeah. And without trivialising it,
you know, could this end up like TripAdvisor for people needing social care? Because that would be really useful.
Yeah.
Because there are lots of good things out there, and lots of still terrible things. And we talk about people making choices and having real choices, and what they need is information. So really and truly, we need all this, but also we need, like TripAdvisor, giving something, you know, 5 stars.
Yeah, I mean, basically, we're kind of teaming up a little bit with Sky, you know, Find Me Good Care, because they've got quantity and we've got the quality. So, you know, there's an element of that, but I'm not sure how useful it is to use TripAdvisor. Do you know what I mean? I think it's not like for like, but, you know, we're definitely... Sorry.
Yeah, I don't really know. I'm not saying to use it, but is it that kind of principle?
Yeah.
Sorry, I'm not. You know, I've not used it. So would it be that sort of principle that you'd be able to look at that and think, well, you know, X is a really good domiciliary care provider. I'm going to try them. Why? You know, it's got really.
I hope so. I hope that it will contribute to people making choices. Definitely. You know, I think that's probably one of the strengths of it.
Would it? You talked about meeting David Bean. Would it actually raise something in an alert? I mean, would you have picked up mid-stabs?
That's an interesting discussion, really, because that's the order of the day. And one of the things that patient opinion has prided itself on is raising alerts. So automatically, if you now subscribe to patient opinion and care opinion, then you will be alerted as to any of the stories. So you get automatic alerts. So yes, it would definitely.
Who would it alert? Would it alert mid-stabs because they registered and they were getting a lot of complaints? But would you, as an organisation, actually say to mid-stabs, you're not registered, but have you realised you've got 200?
Yes. I mean, one of the things that we do, we will alert everybody, because people can, you know, we'll alert you so that you can come back on the post, but the subscription, you know, if you subscribe to patient opinion and care opinion, you end up with like lots of different reports that you can pull out, management reports that you can pull out anyway, but yes, you know, you would be alerted.
But I'd say Winterbourne, where people raise concerns with the CQC, are you a watchguard of the CQC as well?
Well, we're working with CQC. Obviously, David Bean, you know, is a man with a mission, isn't he? He wants to improve the way he does
don't we all,
things.
yeah.
Well, that's only my observation, and that's why he wanted to meet with us, really, because he's quite serious about the role that we can play. You know, so if you can't do, you know, if you think about the plenary this morning, you know, about technology and innovating, you know, I mean, all of these things are merely an aid to an offline world, aren't they? So it's what you make of it, really.
Well, that was the next part I was going to say, because the lady talked about TripAdvisor. I mean, I noticed on the screenshot you got from mid-staffs, there were actually a lot of complimentary things there. Now, the thing about mid-staffs was there was a crisis of confidence by the fact that everybody highlighted the bad, so that all the staff morale had dropped on the basis that they were all being criticised constantly. And is there a positive element to your work as well?
Yeah, I mean, a lot of the majority of stories that come through are positive. I'm not sure, but it's too early to tell with care opinion. But I mean, most people, you know, that have commented, I mean, do have a look, you know, have been very, very positive.
I've looked at patient opinion in the past, care opinion's new on me. But,
well, I hope you'll get active on it.
What's the volumes of stories you get provided weekly, monthly, annually?
Well, it's too early to tell with care opinion. You know, my chief executive always tells a story of 50,000 stories glimmering across the NHS. Do you know what I mean? Because it's not the hard data, it's the qualitative stuff. So, you know, we do.
Is that an aim to get 50,000?
Yes, yes. Well,
and what way are you getting towards that 50,000?
well, I haven't got the exact number for patient opinion, but it's in, you know, it's basically in the thousands. But I will, for the next session this afternoon, I'll get you the exact numbers on that.
And out of that, areas, certain places will have more attention than others, and is that one of the targets or triggers and say there's something happening here for us to look at?
Yes, I mean basically it helps people in their own areas, which I came on to that point about localism. So for example in Southwark, you know, they are using care opinion, they're testing it. So they will use it as their main engagement tool. You know, they've taken a decision, you know, that they want to use it as their main way of engaging users of adult social care. But then, you know, in another local authority, they might just use it as, you know, it won't be you know, their main tool. They just want to know what's happening in their area. Depends what you want to put into it, really.
But what's there some engagement at the moment around changing the model of home care within Kent? So are you saying we could use this as a means of engagement rather than just a passive tool? People engage. We could actually promote people to use it, use questions, or is it that kind of format that we can actually do something quite structured and use it as a platform for our engagement activity?
Yeah.
Ah,
well, you can absolutely do that. And I'll tell you what it is. We've kind of got like a menu of how you can relate to it, because some people want more than others. And some people say, look, you know, I just want to know what's going on in my area. But in Southwark, they have, you know, they said, right, this is an amazing piece of kit. You know, what we're prepared to do now is to say, you know, they felt that in the past, previous administrations have not been that great engaging with users of adult social care. So they're like, right, we want them to comment on not just the providers, but people in the council and anyone that, you know, someone using...
It's all open space, isn't it? It's transparency.
Exactly.
And whatever comes with it.
And also one of the things, which is why I tried to mention it before, this idea that you have other systems in the councils and, you know, and services, you know, this e-marketplace, and, you know, and the more that the connectivity between these things just makes that engagement a lot easier, really. And we've got, like, not to get too technical, but we've got widgets which quite happily sit on your own servers, really. So.
Because there's something about how you link what you get fed back to some of the stuff Dominic was talking about, or other, you know, design people we work with, like active mobbing or whatever. You know, there's elements of how you just draw these different strands together. So you've got different people looking at the problem from a different perspective, isn't it?
Yeah, exactly.
Can you say a bit more about how you publicise patient opinion? Because I must admit it's something that passed me by. I sort of wish I'd known about it. But you know, what were the lessons from publicising patient opinion, and how would you change maybe?
Well, I think really it's a story, the evolution of patient opinion. You know, if you think about 7 years ago now, and we've got this conference today, you know, and there are still people in the conference who are, you know, not active, that don't really understand the power of social media yet. I'm sure that will all change when they walk out the door. But, you know, well, exactly. But if you started 7 years ago, how innovative that was. You know, I mean, I was around at the time doing stuff with local government. I was talking to them, you know, saying, look, how many of you, you know, are using Facebook? And while I was asking the question, they were busy shutting down the use of Facebook in schools, you know, everywhere. So we have, you know, time's moved us on a little bit. So I think we can learn a lot of lessons from patient opinion. You know, they have got a lot of exposure now in the way that they never had before. Because as I said, my opening line to you was, if not now, when really? You know, we've had, you know, you mentioned Winterbourne, we've had mid-staffs, you know, and everyone's saying, you know, we've got to listen to people. So I think, you know, now there'll be more and more publicity. On the care opinion, and I'd be really interested in any comments that you have on this, really, because one of the things that I'm doing to publicise it is like doing deep dives in local authorities that I'm working with as early adopters. And we are, you know, we've got the obvious, like the poster campaigns, we've got the amazing publicity, which I can share with you later, you know, to show, you know, how you can use care opinion. And one of the things we're doing is working very closely with providers, really, to try and get them to promote and engage with it.
I just tweeted our association, actually, Community Care in Kent, and just saying, absolutely, you need to present this at the Trade Association. It'd be really good. You'd be hitting 100 providers in one go. You know.
Healthwatch is very important.
Yeah,
Yeah.
I can answer actually a question about Healthwatch. Well, it was a question, really, because you know, lots of the local health watches are beginning to kind of just get going now, and it's still very fledgling, but we're getting going. I was just interested to know if you were working particularly with any of them in relation to monitoring and how Healthwatch organisations might be engaging.
Definitely.
It's very early to tell, but we're already in there, really, because Healthwatch is, you know, it's really, it's like a match made in heaven, really. I mean, the only thing that stops us from having a national perspective to do it nationally, you know, to hit everyone at once, is that some health watches are further down the road than the others, and so that has been a bit of a teething problem for us. But hopefully, the fact that this is being live streamed now, you know, our phone might be ringing off the hook from health watches that we haven't yet met. But yeah, you know, obviously that's very, very important. I mean, if I may, I wanted to come back to this issue of the providers. I mean, we did a leaflet, and we've really done lots of forums with providers, and all the providers that I've met, once they've met us, have been like, right, we're going to do this, we really want to do this. But it's interesting because we did a pilot. I mustn't have a Freudian slip I mention any provider names as soon as we're going live, but we did a pilot. And one of the providers, the big provider that we work with, they didn't want to publish anything negative.
I've just put on here, do we need to think of social media tools such as this as a different KPI within our how we commission home care going forward?
That's really
so we always think about KPIs in terms of the care and support, whether they're more independent or things like that. But actually, how do we look at how they're engaging and how effective that engagement is and how they're responding to that engagement? So it's turning how we commission services on its head and helping providers to move with that as much as possible.
It's really helpful.
I suppose I'm maybe a bit of a scientist here, I don't know, and
social scientist?
No. Food science.
I'm not another doctor,
And you're generating a large amount of data in the form of stories, which you then have to convert into some form of understanding. What is this actually telling us? Whereas, it's not a random sample. It's people who are thoughtfully passionate, who can go to the trouble, who've got access, who are articulate enough to be able to write a story, or have got people close by who can help them write their story, and so on. And you very usefully tag it, so that just means at least out of this forest of stuff, it's possible to pick up the stuff that maybe relates to Kent or Maidstone or Medway or whatever it might be. But how do you actually draw conclusions other than the most outrageously obvious things like, I shouldn't have used the word outrageous, but say mid-staffs, if there was a continuing stream of really horrific stories there, then it's a means by which you might have found out about it. But you also think, well, there would have been a load of other ancillary information coming through. So what exactly are you giving us that it's just a channel? It seems to be an additional channel. What is particularly great about this channel in relation to, say, people being able to pick up the phone and talk to somebody?
Okay, there are two things to say there. The first one, we may as well get this point out quickly, and that is, all of this, is to help an offline world. It's to help, not to substitute. But one of the things that I would have said is it would be very helpful. This information, should be very helpful, but it's not quantity, is it? Do you know what I mean? It's quality. And one of the things, if you think about my opening line on social media, it's about how you can change things really, really quickly. Patient opinion, they get stories, and some people change the fact that the waiting room looks like a tip, really, really quickly. Do you know what I mean? They can say, thank you for your point, and I've changed it. They've changed it, not real time, but close to real time, in a way that, it wouldn't have happened if you, made your complaint via the usual systems, really. So I think it's that, that it can change things quite quickly.
I suppose sorry, you need to...
Go on.
I'm just slightly worried about management by anecdote.
Right.
And in one of the organisations I actually worked for and helped many years ago, we had to move from lots of expressed opinions that from vociferous people who've got to be in their bonnet. I'll put it polemically just to make it easier.
Okay.
And you have to sort out, the people who shout the loudest, but may actually not have the greatest reason, really, a fundamental reason for shouting loud about this. You have to sort of be able to handle all this noise and work out which is the significant stuff. Yeah, and I think that is part of. If you don't, you end up having to sort of chase around after, almost like headless chickens, from one thing to another to another to another, and not be able to draw out what are the really important things here.
Can you then extract the number of comments that are made by an individual or someone that is feeding in, as opposed to a number of comments that are coming in from a number of different people? So you can show that you have got particular individuals that, you know, because we all know that will happen. You have certain individuals that will. Yeah, and we need to look at that separately, not look at it, because actually it might be that their case manager or someone in health is just they're not hearing them, and they're trying to find
anonymous feedback. You realise that.
But it's about being able to, you know, separate those two. I think, isn't it?
Well, we do get that already, don't we? You know, this is just giving them, as was said in the previous session I was at before, it's just giving them another media to do it.
Yeah.
But we already have that, but we do filter out. The human brain filters out, actually we're getting so much positive about this, and actually 4 people don't like the colour of the wall, but they are very vociferous, and they've written 22 complaint letters, but actually they are. So this is never going to be the only method of feedback. It is just another.
It's helping people like members. It's helping members, etc., for them to understand the wood from the trees.
And it's a better way of communicating. I'm sure it will become a very large. But it won't ever be the sole method of sorting out the weakness.
I mean, I do agree with you to a point, but you know, you have to forgive me for being slightly more aspirational, because while it won't solve everything, I mean, one of the things it will do, for example, in the early adopter authorities, we decide early on who gets the alerts. So don't forget, someone will be alerted as to a story. And, you know, the complaints department, safeguarding, and, you know, it's basically whoever you want to have those alerts. So it's also about how fast people want to react to them. But don't forget, also, and if providers, you know, once they see the colour, the whites of our eyes, they seem to be on board with it. But if we could, in Kent, for example, you know, this is just a real opportunity. You could say to your providers, you know, this is a part of your KPIs. And, you know, basically get them on board. And once they realise that they've got this amazing kit, and it's not, you know, it's not a stick, it's more of a carrot, you know, they might want to interact with it more.
Because they're often saying we don't get positive feedback.
There's got to be a way to take it from the anonymised anecdote. So if you're a provider and you get a feedback and it's about something, an interaction that happened between one of your workers and a vulnerable adult in their own home, you need to know who it was, when it was, so you can tackle that, because that's an issue, isn't it? So can people come back to you and say, I read the anonymised about my, you know, my service, I was very distressed by it, I need the detail, because I need to take that to that individual and deal with it. So there's that opportunity to come back, is there, to you?
Well, there's the opportunity, but because the providers, it's a lot easier than you think, because the providers there and the actual care home or the facility, it's a lot easier than you would think.
Care home's different because it's a care home.
Or domiciliary
care in a home.
Own home.
Oh, right, okay. Yes, well, that's a really good point. So we could, perhaps, you know, Kent could be an early adopter and we could work on that precise issue, actually. Sorry.
I can say something just before we finish. I mean, one of the things I always say if I'm working with private companies around social media is the holy grail of social media is to get your customers to talk about you. Because people will believe what your customers say about you.
Definitely.
So you'll be surprised how many times there are examples on social media of people saying negative things, and then the customers join in and defend it. So no, that's not right. And I think that's what you should do.
And it's providers turning around and very much facing that customer, not facing us as commissioners.
Okay, everyone, I've got Shirley giving me the time out thing, and it would be a brave person to carry on talking when Shirley does that.